So, in today's kind of quick talk or quick lesson, we're going to be doing something I really enjoy talking about, which is rethinking thinking about medicine. And it's an approach to learning, and anybody who's kind of in a teaching role, either for students or for residents or to anybody, this is kind of the way that I don't necessarily want to say recommend, but this is the way that I think about things. And I think it's a pretty good way, because our body does exactly what you think it does most of the time. And it sounds ridiculous, but we've been put kind of into this box where we've been told, here is the differential for this problem and memorize this. And here is the symptoms of this problem and remember it. And then apply it when we go on rounds and stuff like that. And while that may work for some people and it's very raw, you know, the problem becomes you're not actually integrating the physiology and understanding the problem and then putting it into something that will apply to other problems moving forward. And so what I'm hoping to do is try to explain to you the kind of way that I think about problems in medicine and think about scenarios and cases without having to do kind of the raw dog memorization of it. So the first example, these are going to be three different kind of problems that I go through and explain how they are and how they apply. But the first thing to think about is, I ask this to students and residents a lot, is why do you think it's important, and why do you think your body, when you become hypoxic, say to your brain, why is it beneficial for you to pass out and become unconscious? And people look and they're like, oh, well, maybe it decreases the amount of oxygen your brain needs and decreases demand and all this stuff. And it's like, none of that's true. The simple answer is that your brain is above your heart, and your heart needs to pump against gravity to get blood to your brain. And so if you were to fall over, you lay horizontally on the ground, and now there is no more pressure gradient between your heart and your brain. And so from that standpoint, it's beneficial if you don't get blood to your brain or oxygen to your brain to become unconscious and allow blood to go to it. And so that's kind of the process that we're taking in going through these situations, is that we're going to think about what your body would be doing. And it's sometimes it's not always obvious, but a lot of times it's exactly what you think it will be doing and exactly the way you're going to react to it. So the first problem that I present here, and this is a problem that anybody taking USMLE tests will come up with and people on exams, is I call it the pesticide problem. And this problem is usually about a farmer, and he comes in and he has X number of symptoms, usually consistent with a pesticide toxicity. And pesticides, as many of us may know, are acetylcholinesterase inhibitors. And what that means is we're going to have a predominance of acetylcholine in our bloodstream. And as we should remember, acetylcholine is our neurotransmitter for the rest and digest, or the parasympathetic nervous system. And the way you remember that is, well, your sympathetic nervous system is driven by epinephrine and norepinephrine. Everyone knows it's adrenaline, right? Exactly, Rishi. It's always a farmer. And so the question here is, well, what are the symptoms? What is this guy going to present with? And how many of us, and this applies to anesthesia because we always get asked, well, what happens if you give, your neostigmine without giving your atropine or your glycopyrrolate? And the question really is, well, what happens when you have acetylcholine toxicity? And all of these people, at least when I was in school, taught me, well, remember this mnemonic. I think it was the dumbbells mnemonic. And it was, all of the things that happen to you when you get this kind of toxicity. And while that's reasonable in memorizing it for tests and stuff, when you're presented with a physiologic problem, it doesn't get to the issue. And the issue here is you have acetylcholine, and acetylcholine is going to be our rest and digest response. And so really all the question is asking is, pick an organ system and tell me what you think is going to happen when you're resting and digesting. Forget everything you've learned about medicine. Forget all the mnemonics you've learned. Forget about all the things. Because I guarantee you, if I asked a high schooler some of these questions with no background in medicine, and I said, pick an organ, what do you think happens when you're resting and digesting or fighting or flighting? And I gave them two options, they could probably tell me. So if I said, well, what happens to your heart? Well, when you're fighting or flighting, your body needs more oxygen. You need more oxygen to your limbs to be able to run, to be able to fight, to be able to do stuff. And so, oh my God, I definitely erased all of that, and that's because I was leaning on something, so I apologize. So when we rest and digest, our heart is probably going to go ahead and increase its heart rate. Restenosis is going to decrease its heart rate. And the reason is that you don't need to run and fight. So you don't need that increased cardiac output. You don't need that much more oxygen to your body. And so you become bradycardic. And that's a very simple answer, but I'm not thinking about my dumbbells mnemonic here. So what happens to our, say, respiratory rate? Same idea. Our respiratory rate is going to drop. And what happens? How do these patients present? They're usually very wheezy because their airways become constricted, right? Because when you're not running and fighting, you don't need to bring in all sorts of oxygen because you're just sitting there, right? So when we think about other things like our pupils, which is also how we, think about this because it's another presenting sign, our pupils constrict because we're resting and digesting. When you're fighting or flighting, your pupils need to dilate. You need to be able to see more. You need to be able to run. You need to be able to fight. You need to see that fist coming at you, to kind of matrix it. But your pupils are going to constrict. And so when we think about it like this, we're no longer memorizing this mnemonic about, well, I have to remember dumbbells and they have urination. It's like, well, why do you have urination? Well, you're not running or fighting, so your bladder isn't constricting because you're not diverting blood elsewhere. What happens to our GI system? Sometimes we get diarrhea, right? These patients present with loose bowel. And the reason is that your blood is all being diverted from your arms and legs and muscles and things to your gut because it needs to digest stuff. This is the same thing that happens when we have our Thanksgiving meal. Everyone says it's tryptophan, it makes you tired. It's like, that's not what happens. You eat a lot. And when you eat a lot, you get tired because all of that energy is being diverted from your muscles, and your energy to do stuff is now going to your gut to digest. And a lot of you will sit back and you'll breathe slower and your heart will get slower because you've stimulated this major parasympathetic response. And so the kind of idea from this is this patient on all of your step exams or all of these things is going to be, patient comes in, he's a farmer, he has pesticide poisoning, you suspect. He presents with, which of the following symptoms is he going to have? And it's going to be like midriasis. Is he going to be wheezing? Is he going to be loose bowels? And you don't need to memorize this anymore. And this applies to lots and lots in pharmacology, all these kinds of things. We see it with calcium channel blockers. Like, what happens? Well, maybe patient has shunting and you give them calcium channel blockers and it dilates their pulmonary vasculature. You don't need to memorize these things, but we've really been put into this box where it's super important because we think about it for tests instead of clinical scenarios. So that's kind of the first one. The next one that I like to talk about is shock. And we talk about shock because all the time as an ICU fellow, we get called from the ED or we get called from somewhere on the floor and like, we have this patient and we think they're in shock. They need ICU level care. I'm like, okay, great. Tell me about the patient. And so what do they tell me all the time? And what have you all been told as medical students, PA students, nurses? What do we define shock? Well, they have increased heart rate. Great. And they have a decrease in their blood pressure. Okay, wonderful. And they have an increased white count, and they have a fever. Okay, those are all wonderful things. And we gave them, a liter of fluid and nothing's getting better. It's like, okay, that's great. And I'll pose this question to you. When you get sick at home and you have diarrhea or you're vomiting and you have a stomach bug or you have the flu, do you have an increased heart rate? Probably. Do you have decreased blood pressure? Probably. Even though you're not measuring it, your blood pressure is low. Do you have a white count? 100%, but you're not measuring it. And you have a fever sometimes, and we know that, but we don't look at ourselves and be like, shit, I need to go and get, to the ICU and get checked on. That's not how it works. And so really what we need to do here is define our symptoms, and define what our shock is. Shock is lack of oxygen, not perfusion, lack of oxygen to tissue. And the way we remember that is that you can have a hemoglobin of 1, but have a blood pressure of 120 over 90 if you've replaced somebody's volume who's bleeding out with crystalloid and albumin. You're still in shock. You're still not getting you're still not getting oxygen to your organ. And if you think about all other phases of shock, neurogenic, cardiogenic, septic, the problem is perfusion to some degree, but it's the end goal of getting that oxygen to the tissue. So I'm going to pose the question to you. When I hear about this patient from the floor, from the emergency room, I don't care about their heart rate. I care to some degree about their blood pressure, but how many old people walk around with a blood pressure of 90 over 50, and that's completely normal to them, these wide pulse pressures, because that's where they live. They have low MAPs. People live like that. Your liver failure patients live like that because they're super vasoplegic all the time. I want to hear about the obvious causes that are the obvious things that happen in shock. So what do I want to hear about? How do old people present when they come to the ICU or when they come to the rude unhinging of the machinery of life? How do they come to the ICU? How do old people with infections come to the emergency room? They're confused, right? They're altered. They're unconscious. Why? Because they're not getting oxygen to their brain. What happens to their kidneys? They get no urine output, right? They get increase in their BUN and creatinine, okay? Pick another organ system. Sometimes we get shock liver, right? What else? What's the most common cardiac presentation of, lack of perfusion is T-wave inversions, right? Because you have generalized ischemia. And we get tachycardic because our heart is trying to compensate. A lot of times these people breathe faster because remember, they're trying to compensate for their acidosis sometimes, but they're not getting oxygen to their lungs. It's similar to having a PE where you're getting lots of blockage of flow and you're getting lack of oxygen to your tissue. So when I hear about shock and I'm asking people about shock and why they need a bed, I'm not asking them, I don't care about their fever. Lots of people have fevers and they're fine. I want to know about the things that make up shock. And we need to get out of this box of thinking about, oh, well, they have a heart rate, their blood pressure is low. That's all great. I don't care. Are they perfusing? Are they getting oxygen to their tissue? Are they awake? Are they alert? Are they, if you tell me the patient's anuric, they're confused, they have T-wave inversions on their EKG, and that they're breathing at 40 times a minute, that is a much more convincing argument of this person needs ICU level care than their blood pressure is low, they got a fever, and their heart rate's 110. That doesn't matter that much. But we need to, and again, I bring this up because we need to think about things in the context of what is your body doing that makes sense. And when your body doesn't get oxygen, it's going to do very predictable things. And it's important that we think about it that way instead of memorizing what happens when you're in shock. And the last question I'm going to pose to you is, I ask people a lot about shunts and about dead space. And I cannot tell you how many times I've asked people, give me examples of shunting. And they're like, oh, trying to remember back. And we have this picture, the picture of our shunt where it's like, oh, is it, I don't know why my pen keeps turning green, but we have this picture of our alveoli and our blood vessel, and how many times have we gone through this, and it's like, well, shunt is when we don't get anything here, so what's going to cause this? And people tell me pulmonary edema and infection, pneumonia, and those things are great and 100% true. But again, we need to get rid of this idea of memorizing stuff. Because the question is, what is going to prevent air from getting into our alveoli and oxygen from getting into our alveoli while blood is still moving through? That's the question. And the question, you don't need to memorize this. It's very simple. What kinds of things are going to cause lack of air from moving into our alveoli? Well, how about if our alveoli collapse? Atelectasis results in some amount of shunting because blood is moving from one side of the heart to the other side of the heart or any side of the tissue. So we talk about shunts with hemorrhoids or varices or caput medusae. It's going from one part to another without giving up or undergoing gas exchange. We talk about it with our fistulas. That's a large shunt. You're going from arterial to venous without going through gas exchange in tissue. Same thing in the lungs. You go from the right side of the heart to the left side of the heart, or you have a PFO, right to left, large shunt. Those are all types of shunts, and I'm not asking you to memorize this. All it is you're going from one place to another without undergoing gas exchange at a tissue level. And so all I'm asking is, what's going to cause that? Atelectasis causes it. We just mentioned one. PFOs, or Eisenmenger's syndrome, where we go from right to left with our VSDs. What else? How about one that people seem to never talk about or never seem to bring up, but pneumothorax, right? A pneumothorax is a giant shunt because the pneumothorax causes collapse of this alveoli, and now there's blood going through parts of the lung that is not getting ventilation. Obviously we mentioned things like fluid overload, because now you have this fluid level in the lung that's not allowing appropriate air and oxygen to enter in and get transport it across. Any type of pulmonary edema. Same thing kind of with fluid, but it can be from other reasons in like ARDS and things like that. And then the other side of the shunts is just going to be our dead space, which is just asking the opposite question. What is not allowing blood to go through this way? And again, there's a lot of memorization going on, and people say COPD because it kind of just makes sense to them. But how about a PE? Either air or some type of clot or fat. That causes dead space ventilation. Anything that's going to cause, pulmonary artery hypertension, anything that's going to cause lack of blood flow through the pulmonary artery in this case is going to cause some amount of dead space ventilation. And so with all these things, even though I'm giving them to you in like piecemeal, the idea is that I have not memorized any of these things. And it's important that when you treat people, when you're talking physiology, your body's not doing anything that is foreign. It's not doing anything that is, weird. Sometimes it does, but in a majority of cases, it's doing exactly what you expect it to do. And the physiology a lot of times makes a lot of sense. And so I encourage you, we talk about like intra-abdominal hypertension. What are the causes of abdominal hypertension or abdominal compartment syndrome? Well, think of anything that's going to cause pressure on the compartment of the abdomen. Pregnancy, obesity, lots of fluid in there from ascites and your abdomen's distending. If you're laying prone and you have all that pressure from the wherever you're laying in your back, all of these things make a lot of intuitive sense. Don't get into this habit of memorizing because it's going to take you forever to learn things. You're going to forget them when you're done with your test, which can be terrible. But you need to be able to apply this to your everyday critical thinking skills when you're talking about patients, and especially with sick patients, ICU patients, all these kinds of things. You're discussing, well, what could be the cause of this patient's hypotension? Well, think of any reason why blood pressure is going to be low. Is your heart pumping appropriately? Are your vessels constricted enough? Do you have enough volume? And it's not, and then what would cause each one of those things? Are they bleeding? Are they vasoplegic? Do they have neuro damage that's causing vasodilation? And so these things are not things that you should be memorizing. If you have to do it, go for it. But I very much encourage you. We've been put in this box, and I hate this box because this is how I was in medical school, and I was not a good medical student, about thinking about things in the most common sense way, because it's exactly what you think it is. And no one is trying to lie to you, and no one is trying to hide anything from you. It's literally right in front of your face. And I encourage everybody to try and think about it this way. Try to ask the question differently to yourself to get to your answer if you're having trouble. What are causes of intra-abdominal hypertension or compartment syndrome is really just asking what kind of things are going to increase the pressure on your abdomen. And that's a very different question. Or it's the same question, but it's a very different mindset and way of thinking about it. So that's pretty much all I have for this. It's one of my favorite things to discuss, especially with medical students and young interns or new people who are learning, because to me it's a really important way to change the way you think about things, because you're not taking tests anymore. You're doing this because you need to be able to think about how you're going to treat this patient, and you got to get creative with it sometimes. And especially ICU level, things like this, it's really important. If you're not asking yourself these simple questions, you're just like, well, what's the diagnosis? Well, the diagnosis comes with what's going on. So I'm going to go take some questions from here. I'll scroll up real quick. And Rishi, I have to get this quote from you. The founder Samuel Gross described shock as the rude unhinging of the machinery of life. I should put that in my notebook. Can you speak more in depth in fluid resuscitation? Some residents don't want to use it because they say it's not effective. Albumin. So yeah, send me a message and we can definitely talk about that. I'm going to make a video about it because there's a lot of evidence one way or the other. There's not great evidence one way or another, but it is definitely something to discuss. People need to change the way they interpret data when they look at studies. A lot of people, unfortunately, don't read studies. They just read the one-liner, what it says at the end, and they say, albumin did not change, morbidity and mortality at 28 days. It's like, that's not the only outcome you need to be looking at. 1, 2, you need to look at the population studied, because when you don't want to overload somebody with, say, septic shock, who is also in acute heart failure, you can't slug them with crystalloids, even though it doesn't change all that kind of stuff. How do you use mixed venous O2 PA catheters in shock? Are you asking me, or is this like something to go over later? I'm going to personally make sure you send you patients with vague complaints of shock. Thank you, Ethan. I don't know where you are because you didn't answer me, but we can talk about it later. But I hope that this kind of like change the way that you think about things moving forward. And really, you know, pharmacology sometimes can be different because you really need to know the pharmacology of how this works. But my encouragement to all of you is to get into a habit of thinking about things like this, because this is so much more important than being able to answer like what's the dose of this drug is. Because I can look up on my phone in UpToDate. I can ask my pharmacist in the unit. I can go on the computer real quick while I'm on my cow and look it up. But you need to be able to critically think, and asking yourself the question a different way is kind of the way of doing it. So are there any more